مساء الخير. أنا بسمة مدرس neonatology. الكيس بتاعتنا when a baby faces a battle of for oxygen, a case of hypoxic ischemic encephalopathy. On 13th of July 2024, 39 weeks gestational age baby boy was born in our hospital by vaginal delivery. His Apgar score was 134 at 10 minutes and associated positive pressure ventilation immediately after birth, followed by intubation and chest compression. His birth weight was 260 grams. The neonate was delivered and immediately developed apnea, poor tone, and the baby noted to be limp, had difficulty in initiating spontaneous breathing. After stabilization, the baby was transferred to our NICU for further evaluation and management. His mother is 30 years old with FPAL 2012 and had no documented history for follow-up during the current pregnancy. There was a period of decreased fetal movement in the last few weeks of pregnancy, but not reported findings on fetal heart monitoring or ultrasound. She was medically and surgically free and Rh positive group. At birth, he had the mottled skin, marked pallor, and poorly responsive at birth with flaccid tone and no spontaneous movement, no signs of meconium aspiration or staining, with heart rate of 60 beats per minute with central cyanosis. After 10 minutes of resuscitation, heart rate increased to 120 beats per minute. But the baby continued to require respiratory support, so he was connected to mechanical ventilation. On day 1 of life, baby displayed signs of neurological compromise in which he is flaccid, absent reflexes, and lack of spontaneous movement. Multifocal seizures were observed by twitching of the limbs within the first few hours of life, so he was connected to amplitude integrated EEG. Poor suckling, lethargy. He passed meconium during the first few hours of life, and during output was satisfactory. We did the blood gas from the umbilical cord, which shows pH 7, which is severe acidosis, base excess minus 21.6, which means indicated a severe metabolic acidosis with hypoxic ischemic injury. Other labs, normal liver and renal functions, blood glucose showed less than 40 and is corrected. Echo done, moderate PDA with left to right shunting, right ventricular dysfunction, good left ventricular function, and pulmonary pressure 58. So it is a case of hypoxic ischemic encephalopathy, moderate to severe, according to the modified Thurnat scoring, secondary to perinatal asphyxia. Shows a criteria for hypoxic ischemic encephalopathy with the evidence of perinatal asphyxia, the umbilical cord pH less than 7 and base excess more than 12, severe acidosis at birth, the Apgar score within min 0 to 3 at 5 minutes, needs for resuscitation at birth with intubation and chest compression, and evidence of multi-system involvement by respiratory and cardiovascular instability. So the patient admitted with given a moderate to severe nature of hypoxic ischemic encephalopathy, and the early signs show started therapeutic hypothermia initiated in the first 3 hours after birth for the targeted temperature 33.5 for 72 hours to reduce cerebral injury by rectal temperature probe. Other supportive care done, ventilatory support ongoing, mechanical ventilation for adequate oxygenation and ventilation, sedation, light sedation for comfort, and electrolyte glucose monitoring. Cardiovascular support, inotropic support done to improve cardiac output, peripheral perfusion, frequent echo to assess PDA closure and monitor for pulmonary complications such as pulmonary hypertension, seizures management, anticonvulsant therapy, fluid management, electrolyte balance, and started antibiotics. Initially, parenteral nutrition was provided due to a poor oral intake. Once the baby's condition stabilized, enteral feeding was initiated and gradually increased. Continuous monitoring of core body temperature to ensure cooling remains at target. Daily assessment of reflexes, tones, and level of consciousness. Amplitude EEG was used for continued monitoring of seizures during cooling and post-cooling. Serial neuroimaging was done. A cranial ultrasound, no evidence of intracranial hemorrhage or severe ischemia. MRI done at age of 3 weeks, which shows normal. EEG shows a mild background suppression with no continuous seizure activity observed. Continuous anticonvulsant therapy as per neurological recommendation. And family counseling for long-term follow-up for developmental and neurological evaluation. Baby was discharged from our NICU on 28, 2024 at 38 days of life after stabilization and close monitoring. Baby was orally fed and shows satisfactory weight gain during his NICU stay and discharged with normal feeding pattern. Parents were educated on observing any signs of neurological change such as seizures, spasticity, and abnormal movements. Follow-up scheduled at Pediatric Neurology and Neurodevelopmental Clinic, our clinic. Currently, as 8 months is at age now, developmentally baby was rolled over, sat without support and crown. No concerns, baby can grasp objects when placed in his hands and passing from one hand to other hand. Normal social interaction with appropriate eye contact and vocalization. The baby is smiling socially and responding to voices with normal tone and reflexes. There is no concerns regarding neurological deficits at this stage, but follow-up is essential to ensure there is no evolving issues, and vaccination is continued according to the routine schedule. Thank you.